Okay, so good evening all. In today's class, we will be discussing the histology of cartilage and histology of muscles. Okay. Histology of cartilage and muscles. So usually histology questions, most of the times they are image based. Okay, so let's discuss how to identify whether it is hyaline cartilage or elastic cartilage or fibrocartilage, and if muscle is given, histology of muscle picture is given, how to identify whether it is skeletal muscle, cardiac muscle, or smooth muscle. Okay, so we will be discussing in the today's session. Okay, so can you please try to identify what type of cartilage you are seeing in this image? Any idea? Is it hyaline cartilage or elastic cartilage or fibrocartilage? What type of cartilage you are seeing in this image? Yes, this is the slide of hyaline cartilage. Okay, this is a slide of hyaline cartilage. So tell me how to identify this one as hyaline cartilage. What are the points, identification points for hyaline cartilage? Okay, so do you see the outer covering of the cartilage? Okay, this outer covering of the cartilage is called as perichondrium. Outer covering of cartilage is called as perichondrium. You know, outer covering of bone is called as periosteum, isn't it? Likewise, the outer covering of cartilage will be called as perichondrium. Fine. And if you see the inner aspect of the hyaline cartilage, you are able to see the chondrocytes. Okay, all these are chondrocytes. Usually the chondrocytes, okay, they are arranged in groups. Majority of the chondrocytes, they will be arranged as groups. Okay, groups. Fine. These groups are called as cell nests. Okay, so chondrocytes means cartilage cells. In case of hyaline cartilage, they are usually arranged in groups called as cell nests, or okay, cell nests. Okay, they are arranged in groups. Okay, and what type of stain the hyaline cartilage will be taking? Exactly, basophilic. Okay, so the hyaline cartilage is basophilic in nature. Okay, basophilic in nature. Fine, basophilic in nature. Fine, that is blue color. Okay, fine. Then other things about the hyaline cartilage. Okay, so it will be called as homogeneous basophilic matrix. Okay, homogeneous basophilic matrix. Okay, so cell nests, basophilic in nature. Okay, and now we have to know the examples or location of the hyaline cartilage. Okay, any idea? See, hyaline cartilage is the most common type of cartilage. Most common type of cartilage in our body. Okay, that means majority of the cartilage in our body, they belong to hyaline cartilage. Fine. Okay, so coming to the location, as I told, the majority of the cartilages in our body belong to hyaline cartilage. For example, the major part of the respiratory tract. Okay, so the cartilages of the nose. Fine, cartilages of the nose. Majority of the cartilages of the larynx. Okay, then trachea, bronchi, bronchioles. Okay, so you can remember the major part of the respiratory tract, including the nose, trachea, bronchi. Then we have the fetal skeleton. Okay, fetal skeleton. In fetus, the skeleton is made up of hyaline cartilage only. Okay, so the fetal skeleton, then major part of respiratory tract, as I told. Then other location for the hyaline cartilage, one is the costochondral junction. Okay, costochondral junction. Okay, that is costal cartilages, we can say, cartilages of the ribs. Okay, they are also hyaline cartilage. So See this slide, it will be showing the differences between the three types of the cartilage: hyaline cartilage, elastic cartilage, fibrocartilage. Okay, so one important point I told you, the most common type of cartilage is hyaline cartilage, and least common, okay, least common type of cartilage, okay, is fibrocartilage. Okay, and yesterday we have discussed, can you tell me what type of collagen fibers is present in the cartilage? In cartilage, we have what type of collagen fibers? Is it type 1 or type 2 or type 3 or type 4? Yes, type 2. Generally, cartilage is composed of type 2 collagen fibers. Okay, and the exception I have told you, that is fibrocartilage. Fibrocartilage is made up of what? Type 1 collagen. Okay, bone, fibrocartilage, skin, capsule, connective tissue, ligaments, all are composed of type 1 collagen. Okay, so but hyaline and elastic cartilages, they are composed of type 2 collagen fibers. So if the question is generally what type of cartilage, sorry, what type of collagen fibers is present in cartilage, you have to go for type 2 collagen. Right? So as we discussed just now, you know the location of the hyaline cartilage. Okay, costal cartilages, that means cartilages of the ribs. Okay, then nose, not the entire larynx but major part of the larynx. Okay, then trachea, bronchi, fine, trachea, bronchi. Okay, then some other things, fetal skeleton, then epiphyseal plate, you know, epiphyseal plate or epiphyseal growth plate, which is present in the growing bones. It is belonging to primary cartilaginous joint, synchondrosis. Okay, because they are made up of hyaline cartilage, which will be later replaced by bones. Fine. Okay, so majority of the cartilages in our body belong to hyaline cartilage. Coming to the elastic cartilage, I hope you will be knowing the three classical examples for elastic cartilage. Okay, all will start with the letter E. Okay, elastic cartilage, the three classical examples all will start with the E. Okay, number 1, external ear. Number 2, epiglottis, which is one of the cartilages of the larynx. Okay, epiglottis. Okay, then we have the eustachian tube, otherwise called as auditory tube. Fine. So the 3 E's, classical examples for elastic cartilage: external ear, epiglottis, and eustachian tube. When I say external ear, actually it is composed of 2 parts, right? One is auricle, otherwise called as pinna. Okay, auricle or pinna, this one. Okay, then external auditory meatus, both the parts of the external ear, they are made up of elastic cartilage only. Okay, so remember the 3 classical examples for elastic cartilage. Fine. Now coming to the examples for fibrocartilage. Okay, when we talked about the joints, I have told you actually, okay, all the midline joints in our body, for example, pubic symphysis, intervertebral disc, and manubriosternal joint. Okay, all the midline joints, they are made up of fibrocartilage. Okay, and they are belong to secondary cartilaginous joints. All the midline joints, they belong to secondary cartilaginous joints, and they are made up of fibrocartilage. Fine. Then, you know, in the shoulder joint, we have the glenoid labrum, and in the hip joint, we have the acetabular labrum, and in the knee joint, we have the menisci, medial and lateral menisci. Okay, they are also made up of fibrocartilage. Fine. Okay. Then one more important thing is articular disc. Okay, this word articular disc. This articular disc is present typically in 2 joints in our body. One is sternoclavicular joint. Okay, one is sternoclavicular joint. Another one is temporomandibular joint. It is given here. Okay, sternoclavicular joints and temporomandibular joints. Both they have articular disc, which is made up of fibrocartilage. Okay, so please remember the examples for fibrocartilage. Fine. So we have discussed the location or examples for all the three types of cartilages, isn't it? Now, coming to the next important thing about the types of cartilages, perichondrium. You know the meaning of perichondrium, right? It is the outer covering of the cartilage. You can see in the image, perichondrium is present in hyaline cartilage as well as elastic cartilage. But in fibrocartilage, we don't have perichondrium. That's what mentioned here. Okay. Perichondrium is present in hyaline cartilage as well as elastic cartilage, but absent in fibrocartilage. Okay. So, and one more important thing, perichondrium is not only absent. Perichondrium is not only absent in fibro. Okay. Perichondrium is not only absent in fibrocartilage. Okay. It is also absent. Okay. It is also absent in articular cartilage. Okay. And remember, this articular cartilage is actually example for, it is made up of hyaline cartilage. You can see in the hyaline cartilage examples. Okay. Articular cartilage is given, but it is mentioned specifically, it is devoid of perichondrium. So please remember, perichondrium is absent in all the types, all the examples of fibrocartilage and also articular cartilage, which is made up of hyaline cartilage actually. Okay. Now, coming to the chondrocytes. Chondrocytes means, you know, the cells of the cartilage cells. So actually, this is one important point for identifying the slide, whether it is hyaline or elastic or fibro. Okay. So you can compare the points I am going to tell you with the images. So in hyaline cartilage, the cartilage chondrocytes are smaller compared to elastic cartilage. Do you agree? Compare the size of the chondrocytes in hyaline cartilage and in elastic cartilage. Okay. So chondrocytes size smaller in hyaline cartilage, larger in elastic cartilage. Okay. So since the size is smaller, you will find more in number. Okay, more number of chondrocytes in hyaline cartilage, and elastic cartilage, the size is, chondrocytes are larger in size, so they are less in number. Number will be less. Okay, fine. And so that's what mentioned here. Smaller compared to elastic cartilage. The chondrocyte size in hyaline cartilage is smaller. So in elastic cartilage, the chondrocytes are larger, you know, isn't it? Fine. And how will you identify the slide of fibrocartilage? How will you identify the slide of fibrocartilage? Yes, there is no perichondrium. That is one point. Okay. Another important point is you can see the chondrocytes are arranged in rows. They are arranged in rows which are widely separated by the collagen fibers, type 1 collagen fibers, isn't it? Type 1 collagen fibers. Okay. Right. This is how you have to identify whether it is a slide of hyaline cartilage or elastic cartilage or fibrocartilage. And you can clearly see in fibrocartilage, what is the type of the nature of the fibrocartilage in H&E stain? Yes, it is eosinophilic in nature. It is mentioned in the tabular column itself. It is eosinophilic. Okay, pink stained, isn't it? It is eosinophilic, pink stained. Okay. What about the hyaline cartilage we have studied? Yes, it is basophilic in nature. It is basophilic in nature, blue color, blue stained, isn't it? Okay. And you will be knowing in the one more important thing about hyaline cartilage is it is made up of, okay, why it is homogeneous. This question may be asked. Why the matrix, okay, extracellular matrix in hyaline cartilage is homogeneous. Okay, because the collagen fibers, type 2 collagen fibers, okay, and ground substance both are having the same refractive index. The refractive index of the collagen fibers and the ground substance is similar, same. Fine. That is the reason for the homogeneous matrix of the hyaline cartilage. So I hope you are clear about the features of the three types of the cartilage. Fine. Okay, fine. Now Can you tell me, out of these three types of cartilages we have studied, which cartilage, which type of cartilage has the tendency to ossify or calcify? Any idea? Yes, hyaline cartilage. Okay. The characteristic feature of hyaline cartilage is it may undergo, okay, it may undergo ossification. Ossification means formation of bone. Cartilage may be converted into bone. Okay, that means due to the process of deposition of calcium. Okay, so if there is calcium deposition taking place in cartilage, it will be converted into bone, isn't it? Okay, so hyaline cartilage has the characteristic feature of undergoing ossification and calcification, mainly in elderly age. Okay, but the other two types of cartilages are there, right? Elastic and fibro. They do not undergo ossification. Okay, other two types of cartilages, they do not undergo ossification. Remember this important thing. Okay, now so we have talked about the types of cartilages. Let me talk about the types of muscles for the next few minutes. Okay, types of muscles, again histology only. So if a slide of muscle image is given, how can you identify whether it is a slide of skeletal muscle or cardiac muscle or smooth muscle? Okay, any idea about the first slide you are seeing here? It is a slide of skeletal muscle. Okay, it is a slide of skeletal muscle fibers. Okay, so how I am saying this one as skeletal muscle slide? Because the points for identifying the skeletal muscle image or slide is, you can see, do you see the various nuclei which are taking the blue color stain? Okay, various nuclei. So the skeletal muscle fibers, okay, the skeletal muscle fibers, okay, they have multiple nuclei, multinucleated, okay, multinucleated, or you can say they have multiple nuclei. Okay, and these nuclei are peripherally placed. You can easily appreciate. Okay, so this is one very important point for identifying the slide of skeletal muscle. Okay, what is the point? The skeletal muscle fibers have multiple nuclei which are peripherally placed. Okay, peripherally placed multiple nuclei, multinucleated. Is it fine? Okay, and you will be knowing another important point. Skeletal muscle fibers are otherwise called as striated muscle fibers, striated muscles. Okay, so do you observe the striations present in the skeletal muscle fibers? All these are striations present in the skeletal muscle fibers. That's why the skeletal muscle is also called as striated muscle, isn't it? And you know one more thing about the skeletal muscle, it is voluntary in nature. Skeletal muscle fibers are voluntary muscles. Okay, they are voluntary in nature. Okay? And the examples for the skeletal muscles you will be knowing, isn't it? All the muscles present in our limbs, upper limb and lower limb, since they are attached to bones, they are skeletal muscles, right? And moving to the second image, any idea about the slide? Whether it is, can you tell me whether it is a cardiac muscle or smooth muscle? That's my question. Yes, this is a slide of cardiac muscle. Okay, cardiac muscle. So how to identify the slide of cardiac muscle? Okay, you can see the cardiac muscle fibers. I am tracing the cardiac muscle fibers. Okay, they are branching. Okay, they are branching and anastomosing with each other. Okay, so cardiac muscle fibers are branching. Okay, they are branching and they are anastomosing with each other. Okay, cardiac muscle contains branching and anastomosing fibers. Fine. And what about the nature? What about the nature of the nucleus? What about the nature of the nucleus present in the cardiac muscle? Yes, single nucleus which is centrally placed. Okay, single centrally placed nucleus, unlike skeletal muscle fibers which has multiple peripherally placed nuclei. Okay, cardiac muscle fibers have single nucleus and it is centrally placed. single centrally placed nucleus. Fine. Okay. Now, one more very important thing about the cardiac muscle fibers is, okay, it contains the so-called intercalated disc. Okay, intercalated disc is a characteristic feature of what? Cardiac muscle fibers. Intercalated discs is a characteristic feature of cardiac muscle fibers. Okay, through the intercalated disc only, the impulses will be rapidly conducted from one muscle fiber to the another muscle fiber. Okay, so the intercalated disc play very important role in rapid conduction of the cardiac impulses. Fine. Yes, let's move to the third slide. Obviously it will be the smooth muscle fibers. Okay, this is the slide of smooth muscle. Okay, slide of smooth muscle. As you see here, the smooth muscle fibers, okay, they are spindle shaped. They are spindle shaped fibers. Okay, smooth muscle fibers are spindle shaped. Okay, actually, since this is a low magnification, you may not be able to appreciate clearly, but still remember the smooth muscle fibers are spindle shaped. Okay, and again, the nucleus is centrally placed nucleus. Okay, centrally placed nucleus. The muscle fibers have centrally placed nucleus. Fine. And you know the another name for the smooth muscle fibers, isn't it? They are, yes, non-striated, no striations, isn't it? So they are non-striated muscle fibers. Okay, non-striated muscle fibers. Smooth muscle fibers are non-striated, isn't it? And also you will be knowing smooth muscle fibers are involuntary. Involuntary muscles, isn't it? What about the cardiac muscles? Cardiac muscles are also involuntary. Involuntary. Cardiac muscle fibers are also involuntary, similar to the smooth muscle fibers, isn't it? But remember, cardiac muscle fibers have slight or mild striations. Okay, they have slight or mild striations. Fine. Striations may be mild or light. Okay. So I hope you can identify the types of cartilages and the types of muscle fibers by the various features we have discussed for the past 10 to 15 minutes. Okay. And what are the examples for the smooth muscle fibers? All the muscles present in the various system like gastrointestinal tract, respiratory tract, okay, genital and urinary tract, okay, all the systems in our body, okay, they are made up of smooth muscle fibers only. Okay, and the muscles present in the upper limb and lower limb, they are example for skeletal muscle fibers. Cardiac muscle obviously present in the heart. Okay, so that's the end of the today's session. Thank you all. Thank you.
Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Okay. So good evening. Today we will begin off with aplastic anemia. The recent NEET PG had asked a question about aplastic anemia. They had given a bone marrow picture and they had written a bony spicule or a trabeculae with only fat spaces, isn't it? So that answer was aplastic anemia. So we will see that topic today. Which one of these, by the end of today's 15-minute session, we should be able to answer these. Which one of these is a feature of blood count and bone marrow in patients with severe acquired aplastic anemia? That's one thing. And then next one is, which one of the following marrow failure syndromes also include exocrine pancreatic dysfunctions? So these are the two potential questions I think is important for you in this concept or topic, because it was asked in your last NEET PG. Okay. So when coming to one thing, we have to understand that, see, pancytopenia. See, pancytopenia means what? There is reduced HB less than 10 gram per deciliter. Okay. Then there is a reduced WBC count less than 4,000. Okay. 4,000 cells per cubic millimeter of blood. Okay. And then there is a reduced platelet count less than 1.5 lakh. Isn't it? So this is in general pancytopenia. Fine. So there are various causes for pancytopenia. Okay. So what are the causes for pancytopenia? Whenever there is acute infection, okay, there will be decreased marrow functions. There will be a sudden pancytopenia and then they will recover. The next one and the most important is aplastic anemia, which we will be dealing in detail today. Okay. And then along with that, acute leukemia. The case is called aleukemic leukemia, where there will be pancytopenia, but there will be blasts. Okay, that is important. In myelodysplastic syndrome, there will be pancytopenia. Along with that, there will be abnormal morphology of the cells. That is very, very important. Whenever there is infiltration with lymphoma, myeloma, metastatic solid tumors, that time also we can see pancytopenia. Most important, other important cause is vitamin B12 and folate deficiency. Megaloblastic anemia, there is pancytopenia. That is why in megaloblastic anemia, there will be reduced WBC count and platelets along with anemia. Okay, PNH, yes, very, very important cause of pancytopenia. But here the marrow will be cellular marrow with pancytopenia. Myelofibrosis, there will be myelofibrosis in the marrow. That is one distinctive feature along with pancytopenia. In hemophagocytic lymphohistiocytosis, see, each point I'm telling is a question. Hemophagocytic lymphohistiocytosis, you will see hemophagocytosis. That is, phagocytic cells will have either lymphocytes or neutrophils or RBCs. That is hemophagocytic lymphohistiocytosis associated with Epstein-Barr virus, and they will also present with pancytopenia. Okay, and whenever there is increased peripheral destruction, this is not very important. So that is, but splenomegaly is again a very important cause of pancytopenia, because there will be this is called hypersplenism. This is called hypersplenism. Okay, why? Because there will be increased pooling. There will be increased pooling, and there will be increased RBCs and WBCs and platelets stagnant in the spleen. Especially in hypersplenism, what is the characteristic? That is also an important question. What is the characteristic feature is there will be pancytopenia with all these above said features, and the marrow will be cellular. That is very, very important. Marrow will be cellular. Okay, and whenever there is splenectomy done for this patient, whenever splenectomy is done for this patient, what will happen is these values will revert back to normal. That means the hemoglobin will be correct. In all these causes where I told you, what is very important, what you have to remember, causes for hypercellular marrow with pancytopenia, I want you to remember paroxysmal nocturnal hemoglobinuria. Okay, and increased peripheral destruction, hemophagocytic lymphohistiocytosis, and hypersplenism. Okay, in all other conditions, there will be reduced marrow function, but some marrow function will be retained. Okay, and now we will see an important cause, aplastic anemia. Tomorrow we will see paroxysmal nocturnal hemoglobinuria. So when it comes to aplastic anemia, you have congenital causes and acquired causes. Okay, acquired causes like other disorders, ionizing radiations, chemicals, benzene. This also was a question, isn't it, recently? Benzene, okay. And then viruses, okay, autoimmune disorders, transfusion associated graft versus host disease, and thymoma. Thymoma is associated with red cell aplasia. This was also an important question recently. Okay, so all these are the acquired causes. In these acquired causes, you have to remember thymoma, okay, and viruses. Okay, so now we will go in detail about congenital disorders. Okay, so one important point I want you to remember is, see, you have to know that aplastic anemia is a cause of pancytopenia. So there are many causes. Now it's very sure, you are very sure, because you have seen the tabular column, you know that cellular and hypocellular marrow will be there. So you have to know this aplastic anemia is a cause of pancytopenia. Okay, that is the first point, because it's an English based question. Okay, old question, but English based question, they might ask you again. And then next one thing is, what happens here is the marrow is hypoplastic. What happens to the marrow? The marrow in aplastic anemia is hypoplastic. Okay, so there is a reduced number of hematopoietic pluripotent stem cells. There is a reduced number of hematopoietic pluripotent stem cells. In this disorder of aplastic anemia, I am going to concentrate on three things: Fanconi's anemia, dyskeratosis congenita, Schwann-Diamond-Blackfan syndrome. Fine. Okay. Then, so this was the image, isn't it, which was given in your recent NEET PG. Okay, so we will see in detail about Fanconi's anemia, whatever are the potential questions. Okay, first thing is, it is autosomal recessive. You have to know. Okay, the genes, there are many genes identified. The genes Fanconi's from A to Q. Fanconi's A, Fanconi's B, like that. Okay, from A to Q. Okay, one more important thing you have to remember here, these chromosomes of these patients, they have high tendency to undergo spontaneous breakage. Spontaneous breakage of chromosome. Spontaneous breakage of chromosome. Usually they will present at 3 to 5 years of age. Okay, so what all they can present as? They can present with growth retardation. Okay, skeletal abnormalities like microcephaly. Okay, skeletal abnormalities like microcephaly. Okay, absent thumb, absent radii. Okay, congenital defects like of kidney, like horseshoe kidney or pelvic kidney. Okay, so kidney disorders. Okay, congenital disorders of kidney. Okay, and skin, they may show hyper or hypopigmentation. Hyper or hypopigmentation. Okay, here I want you to remember this point very much, because spontaneous breakage of chromosome is very, very important. Why it is important is, this is again used for diagnostic. Okay, diagnostic purpose. Okay, so when we add DNA cross-linking agents like DEB or mitomycin, okay, we will see excess breakage in Fanconi's anemia like this. See here, there is excess breakage. Okay, on adding mitomycin or DEB. This is a question, very important image-based question. Fine. And then next, see here, this is a patient with Fanconi's anemia, image-based question. The thumb is absent. Okay, and in this patient, if you see, this kidney is placed in the pelvis. Okay, the kidney is placed in the pelvis. Fine. Okay. Okay. And then this patient's marrow, when we see the marrow, the only thing we will see is fatty aspirate. It will be like this. Okay, usually for any age we see, say for example, the patient's age is 50 years, this fat is to marrow component, or the hematopoietic cells ratio should be 50:50 or 1:1. Okay, so 50% should be fat and 50% should be marrow component. But in this patient, in usually with aplastic anemia, any aplastic anemia, usually there will be fat predominance more than what we expect for that age. So this is the bony trabeculae. Okay, and if you see, there are hardly any marrow particles, it is full of fat. So this was the image given, and it is a image of aplastic anemia. That was the option given. Okay. Okay, so after this, one important a few lines regarding disc keratosis congenita. Okay, what you have to the triad is very important here. Okay, this triad is nail dystrophy, okay, lacy reticular pigmentation, okay, usually in the upper chest and neck, lacy reticular pigmentation, this is important, nail dystrophy, this question is asked many times, okay, and oral leukoplakia. How I remember is one nail, one skin, and one mucosa. So nail dystrophy, okay, lacy reticular pigmentation of the skin, and oral leukoplakia. Okay, the mutations, the genes are disc keratosis congenita 1 gene, okay, TERC and TERT. Okay, telomerase shortening, telomere shortening is seen in these disorders, like how their breakage I told you in Fanconi, here it is telomere shortening. Telomere shortening. Fine, this is important. And then next disorder what we have is Schwann-Diamond-Blackfan syndrome. Okay, this is autosomal recessive. Okay, they will have cytopenia, neutropenia, they may progress to AML, MDS, but what is important was with these pancytopenia features, they will have exocrine pancreas deficiency. Very, very important question. Exocrine pancreas deficiency. So quickly going to the questions, which one of the following marrow failure syndromes includes exocrine pancreas dysfunction? It is Schwann-Diamond syndrome. Schwann-Diamond syndrome. Fine, not Blackfan-Diamond syndrome. It is Schwann-Diamond syndrome. Which one of these is a feature of blood count and bone marrow in patients with severe acquired aplastic anemia? Okay, which one of these is a feature of blood count and bone marrow in patients with severe acquired aplastic anemia? Abnormal blast cells, I told you, in aplastic anemia, there will be hypocellular marrow, but no abnormal blast cells. So the WBCs will be reduced, platelets will be reduced, RBCs will be reduced, but you will not see any abnormal blast. So if you're seeing any abnormal blast, it is going into aleukemic leukemia. If you're seeing abnormal morphology of the cells, it will go into MDS. But if you in case of aplastic anemia, they are normal cells. So this option is wrong. Then hyperplastic bone marrow. No, in aplastic anemia, I told it is hypoplastic bone marrow. So this option is wrong. Reduced number but normal appearance of neutrophils on the blood film. Yes, the cell counts are reduced, but they all appear normal. Normal lymphocyte count is also reduced. So this option is wrong. So this is the first question. Next question is, which one of the following marrow failure syndromes? That is Schwann-Diamond syndrome. For Fanconi's anemia, they'll usually give an absent thumb or radii or congenital defects in the thing. Okay, fine. So we'll just look at the images again. This image where there is a bony trabeculae and fatty marrow, okay, only fat in the fat spaces or fat globules in the marrow. This is suggestive of aplastic anemia. Recent last question, NEET PG question. Okay, and then next one is absent thumb. Here you have to notice, if they give you a hand like this and they tell the hemoglobin and WBCs are reduced, you have to think of Fanconi's anemia. Any skeletal abnormalities, first thing you have to think of is Fanconi's. Okay, congenital renal abnormalities also you have to think of Fanconi's. See, for treatment for Fanconi, I would just like to add androgens and even for dyskeratosis congenita, the treatment is same. Androgen and stem cell transplantation. See, androgens will improve the blood count of female baby. It is going to have its own side effects because androgen induced side effects. Okay, so this is mitomycin C induced chromosomal breakage. Fine, this is very, very important. Hope you have understood understood the class today. Okay, thank you.
So, good evening. We'll start with another important topic in microbiology, that is your Vibrio cholera, which causes cholera, which we know it's a diarrheal disease. So, this is gram staining picture of Vibrio cholera. This is the gram staining picture of Vibrio cholera, which shows comma shaped bacilli. This is gram negative bacilli. So, it's comma shaped, you can see. And it has special motility, which is called darting motility. Darting means you cannot track the path of the organism. It comes and goes off. So that we say it as a darting motility. So Vibrio cholera has a darting motility, which has been asked previously, and it's very important question for your entrance test. What kind of motility Vibrio cholera shows? So this is hanging drop preparation. What slide you are seeing? This is a hanging drop. Hanging drop is a method to demonstrate the motility of the organism. So this is the hanging drop. So this picture was given and it has been asked what kind of motility you see and which organism is this. So you can see there are curved bacilli. So that is your hanging drop showing curved bacilli. So it is Vibrio cholera. Now, as it is GNB, gram-negative bacilli, you can culture on McConkey agar. McConkey agar, first it shows non-lactose fermenting colony, does not ferment lactose, so it will be colorless colony. Then it changes to late lactose fermenter, which is the transport media for Vibrio cholera. It's VR media, which is called Venkatraman Ramakrishnan media, and another one is Carey Blair media. These are the two transport media for Vibrio cholera, right? This has been asked previously. VR media and Carey Blair media is a transport media for Vibrio cholera. Transport media we use in a situation when you expect there is a delay in transport of specimen, or you sample from where you are collecting the sample is a remote area and you are sending to a lab which is far from your place. So there is a time gap. In those situations, you use transport media. Okay. What is the enrichment media? Enrichment media for Vibrio cholera. Enrichment media will be always liquid media. So you have alkaline peptone water, you have Monsoon's taurocholic telluride peptone water. Okay. What is the selective media for Vibrio cholera? What is the selective media which allows only Vibrio cholera to grow? That is your TCBS. TCBS is thiosulfate, citrate, bile salt, sucrose agar. TCBS. In that, Vibrio cholera, because it ferments sucrose, right? Thiosulfate, citrate, bile salts, sucrose agar. So it gives yellow color colony. Okay, which organism ferments sucrose, they give yellow color. So it gives yellow color colony on TCBS. This has been asked previously. So you should know which is the transport media, the VR media, Carey Blair media, which is the enrichment media, alkaline peptone water, which is the selective media, TCBS, where it gives yellow color colony because of fermentation of sucrose. Now, what is the string test? You can see. Okay, this is your string test. String test is one of the identification tests for Vibrio cholera. So it when you mix with a drop of sodium deoxycholate on a looful of slide, it gives string. Okay, there will be loss of turbidity, mucoid appearance, and when you pull it, it forms a string. So string test we do in a Vibrio cholera. Okay, so this also picture can be given and question can be asked what kind of test this is and you do for which organism. Now coming to halophilic and non-halophilic Vibrio. Okay, so this has been asked previously, which is halophilic Vibrio. Please remember, parahemolyticus, alginolyticus, and vulnificus are three halophilic Vibrio. Parahemolyticus, alginolyticus, and vulnificus are three halophilic Vibrio. Your Vibrio cholera is not halophilic; it is non-halophilic Vibrio. Okay. So what is the antibiotic we use? Okay, so you can use erythromycin, azithromycin, or cotrimoxazole in a children and pregnant women. Okay, so you have one group, children and pregnant women. Okay, and you have another group, adult. There you can use doxycycline as a treatment of choice for Vibrio cholera. So it causes rice watery stool, right? We know Vibrio cholera disease, the most characteristic feature patient will present with is rice watery stool, okay? And most of the time it will be self-limiting, but in few situations you need to start treating with antibiotic. So what other biochemical reaction you have? You have, it will be catalase positive and it is oxidase positive. So two tests you will be seeing positive. We have seen the picture of catalase earlier. We have seen the picture of oxidase test earlier. So these two tests will be positive. Now they give cholera red reaction positive. So this is your cholera red reaction. Okay. So in nitrate peptone water, they produce indole from peptone and reduces. So they produce indole and reduces nitrate to nitrite. So this is cholera red reaction when you add sulfuric acid. Okay. So this red color reaction you get. So it is indole positive. It gives cholera red reaction positive. Now, what is the classification we use? It's Gardner-Venkatraman classification, which we use for Vibrio cholera. Okay. So what is the classification? Gardner-Venkatraman classification. So first you classify into two groups. One is Vibrio cholera, other Vibrio species. Now you classify into subgroups or serogroups, okay, or serowords. Any terms can be used, okay. So Vibrio cholera has O1, O139, and other Vibrio will have O2 to 200 and above. Okay, so O1, O30, 139 comes to Vibrio cholera, other will have O2 up to 200. Now O1 will further classify into biotype, classic and Eltor biotype. Okay, and they further classify into serotype, or both of them, classic and Eltor will have three serotype: Ogawa, Inawa and Hikojima. Okay, these are the list of differences between classic and Eltor. So VP positive, Vox-Prosker reaction positive is your Eltor, which has been asked. Most probable other question can be, which is polymyxin B sensitive? So classic is sensitive. Okay. So these all can be asked. Which shows hemolysis? So Eltor shows hemolysis. Infective dose 10 to the power 8. How it acts? You have a cholera toxin, okay, which causes ADP ribosylation of G protein and causes increase in cyclic AMP, which has been asked earlier, increases cyclic AMP. Okay, so how the cholera toxin acts? By increasing cyclic AMP has been asked, and very favorite your entrance test questions. It can be modified and asked in a different way. Other virulence factor, it has zona occludens toxin, which has been asked recently in 2015. It has CD4, but lipopolysaccharide doesn't have any role. We know gram-negative lipopolysaccharide is toxin, mediates toxin release, or it's toxic. But in Vibrio cholera, lipopolysaccharide doesn't have any role in virulence. Okay. So till now, we have seen 7 pandemic of cholera, where 6 pandemic has started from India. Okay, 7th pandemic was only little different from all remaining 6 because it started outside India. It started in Indonesia, and all 6 pandemic was because of classic. The 7th pandemic was because of Eltor. Okay, and all 6 pandemic has more morbidity, mortality, several thousand death has been seen, and it is milder form. The 7th pandemic was milder form and more on a carrier state. More of the patient has gone on a carrier state. Okay, so we discussed Vibrio cholera, important questions, which about toxins, about their string test, about their oxidase catalase. Then these all can be asked probably exam question. Okay, now it's coming to another important topic, Pseudomonas. Small but few question which has been asked frequently in Pseudomonas, pigment production. Pseudomonas is one of the bacteria which produces pigment. Okay, so Pseudomonas aeruginosa which produces pyocyanine, pyoverdine, pyoribin. Cyanine will be blue-green color. You can see it will be seen most nicely. It will be seen on nutrient agar plate. Blue color, pyocyanine, blue-green color. Pyoverdine will be yellow-green. Pyoribin will be red-brown. So three color produced by Pseudomonas aeruginosa. Pyocyanine, pyoverdine, pyorumin. One more color can be produced, that is pyomelanin, which will be black in color. Okay, so these are the pigment production by Pseudomonas. They are motile. Okay, they are motile by single or multiple polar flagella. They are strict aerobes. Okay, they are oxidase and catalase positive. They are non-fermentative. So those all which we saw till now we read, those all were lactose fermentating or late lactose fermentating. This starts the non-lactose fermenting organism, that is your Pseudomonas. Recently in the NEET entrance also it was asked oxidase positive about Pseudomonas. So it is oxidase positive. It causes burn and wound, which has been asked this year. Burn and wound infection caused by which organism commonly, and which is oxidase positive, strict aerobes. So this is your Pseudomonas. It can cause pneumonia, cystic, especially chronic infection in cystic fibrosis patient. It can cause CNS infection, endocarditis, UTI, bacteremia. One important, ecthyma gangrenosum, which is acute necrotizing skin infection, which results from bacteremia in AIDS positive, HIV positive patients. Okay. So how it acts, Pseudomonas, they inhibits the elongation factor 2 and inhibits the protein synthesis. So Pseudomonas acts by inhibiting protein synthesis. Okay. What are the treatment? What is anti-pseudomonal penicillins? So it is carbonicillin, it is ticaracillin, it is piperacillin. These are having anti-pseudomonal activity. So please remember, this also has been asked in your exam, anti-pseudomonal penicillin. Carbonicillin, ticaracillin, piperacillin are commonly used anti-pseudomonal penicillin. Thank you. So we'll meet again with some interesting topic in microbiology. Till then, thank you so much. Bye.
So hello. So once again we have another important session for INICET. So this is blend force zones. So I'm going to the slides. Yes. So we'll go to the first slide. So the blend force zones are abrasion, contusion, laceration, fractures. So some textbooks include firearms as blend force zones too, right? So technically blend force zones are abrasion, contusion, laceration, only the first three. So some text includes fractures as well as firearms in blend force zones, right? So out of which we'll cover abrasion and laceration today, right? Okay. So next slide, please. So we'll go to the abrasion. So first kind of abrasion is point abrasion, point abrasion. See, point abrasion is otherwise called as scratch abrasion or linear abrasion. So scratch abrasion, linear abrasion, point abrasion, they're all one and the same, right? Other names, scratch abrasion, linear abrasion are other names, okay? So why is it called point abrasion? Means the injury is caused by pointed objects, right? Pointed objects or objects with pointed ends, weapon with pointed tip, right? All are correct. So weapon with pointed edge or weapon with pointed tip or pointed objects, right? Example, pin, pencil, needle, extreme tip of knife. So you could remember pin, thorn and all. So also remember extreme tip of knife. So the extreme tip of knife can cause point aberration, right? Or linear aberration or scratch aberration. It's technically a straight line, right? A straight line. So the animation, please. So the photo will come. Yes. So look at the photo. In the arm, in the arrow, the red color arrow indicates all linear aberrations or point aberrations. You could see black lines, right? Black lines, okay, straight lines. Okay. So now please pay attention. Scratch aberration or point aberration is technically a straight line caused by pointed objects. Yes. Now there is a situation where there is an entity called crescent aberration. Crescent, like a moon, right? Crescent aberration. See, crescent aberration is nothing but fingernail scratch. So scratching with fingernails, right? Scratching with fingernails will produce linear aberration or scratch aberration called crescent aberration. This is a specific name used for scratch aberration caused by fingernail. So it was an AFMC question, a repeat AFMC question. So crescent aberration is a type of scratch aberration. It is caused by fingernails, right? Caused by fingernails. Okay. So next slide, please. So we'll go to next slide. Right. So next slide is grace aberration, right? Grace aberration. So the first type of aberration is point aberration that we saw in the previous slide. So this slide we are dealing with grace aberration, right? Grace aberration. Grace is nothing but grazing is over a large area, right? Grace is just an English word which means over a large area, over a large area. So other name for grace aberration is brush burn, right? Brush burn. Remember, brush burn. Okay, so the photo, please. Yes, so brush burn, like painting using a brush, right? As though you are using a brush. The wound will look like brush markings, right? Brush markings. Hence, grace aberration is also called as brush burn, right? Brush burn. Okay, so it involves a large area of contact. So point aberration is only on point, extreme tip, whereas grace aberration involves a large area of contact between the blunt force and the body, right? Blunt force on the body. So most commonly brush burn is seen in road traffic accidents, right? Most common causative factor for brush burn is road traffic accident, right? Okay, so over a large area of contact. So brush burn is technically grace aberration, grace aberration. So again, I'll tell you one more additional point, extra nugget you can remember. Friction burn, friction burn. Friction burn is nothing but grace aberration with clothes. A person is wearing clothes and has got grace aberration. It is called a friction burn. Whereas brush burn is grace aberration with lesser clothes, right? Lesser clothes. Grace aberration would be brush burn, lesser clothes. It is called friction burn with more clothes, right? More clothes. Okay, right. So we can go to the next slide. Yes, next slide, please. Yeah. See, this slide is another important slide, right? Another repeat MCQ area. Repeat MCQ area. So please remember, point aberration and grace aberration, they have a similarity, right? So there are two types of aberrations. Yes, they have a similarity. So what is that similarity? Both point aberration and grace aberration are caused by tangential force. Tangential force, right? Tangential force. See, it is nothing but force acting on the skin, right? Skin pushes the epidermis or superficial layers to one end. So force acts on the body, so pushes all the epidermis from one end to another end. So it is called a heaped up epidermis, right? Heaped up epidermis. So epidermal heaping, epidermis will be pushed from one side to another side. So this epidermal heaping indicates direction of force, right? This epidermal heaping indicates direction of force. So you can find a direction of wound. Technically, direction of wound is nothing but direction of force, right? So direction of wound or direction of force from point aberration or grace aberration using heaped up epidermis, right? Heaped up epidermis. So I tell you, this heaped up epidermis is because of the tangential force, right? Because of tangential force. So tangential force, you can find direction of force with the help of heaped up epidermis, useful for point aberration and grace aberration, right? Okay, so important point. So next slide, please. So next slide, we'll see about another two kinds of aberrations. So two aberrations we saw: point aberration, grace aberration, and similarity between those two. So two more kinds of aberration are there. First is impact aberration, right? Impact aberration. See, impact aberration is nothing but direct impact over a hard surface, or just hitting against a wall or falling onto a surface, right? Direct impact. This is impact aberration, hit on a hard surface. Then pressure aberration. Pressure aberration is due to sustained pressure over a particular area. So over a particular area of skin, there will be a sustained pressure. It is called pressure aberration, right? Pressure aberration. So there is a similarity between impact aberration and pressure aberration. See, impact aberration and pressure aberration are collectively called as patterned aberrations. Patterned aberrations or imprint aberrations. Imprint aberration or patterned aberration. So you can identify pattern of the weapon or pattern of the object causing the aberration, right? So we'll have the photo, please. Yes. So look at the forehead. Look at the forehead where the arrow indicates. This is impact aberration, just hitting against a hard surface, right? So next photo, please. Yes. So look at this. It's so easy to remember. Pressure aberration. Example for pressure aberration is ligature mark in hanging. In hanging ligature mark, right? Pressure aberration is because of sustained pressure, right? Sustained pressure. So patterned aberrations are pressure aberration and impact aberration. Okay. So we'll go to the next slide, right? Next slide. So next slide is nothing but healing of aberration, right? Healing of aberration. So healing of aberration is one of the repeat area for PGI. PGI, they used to ask healing of aberration and healing of contusion, right? So first we'll see with healing of aberration. See, healing of aberration, you can remember it as 1 day, 2 day, 3 day, 4 days. See, continuously it will be there. So fresh aberration will be bright red. So up to 1 day, there will be a red scab. So scab formation starts. So scab formation starts between 12 to 24 hours, right? So red scab. So scab becomes brown, right? Scab becomes reddish brown between 2 to 3 days, right? So there will be scab formation, which is red in 12 to 24 hours. The red scab gets converted into reddish brown between 2 to 3 days. The reddish brown scab will become brown or black scab between 4 to 7 days, right? 4 to 7 days. So what happens after 7 days? The scab falls off. Once the scab falls off, there will be depigmented patches, right? Depigmented patches. Most repeat MCQ is scab formation starts by 12 to 24 hours. Scab becomes black by 4 to 7 days. Those are two repeat areas, right? Two repeat areas. So fresh aberration, bright red. So 12 to 24 hours, there will be red scab formation. So 2 to 3 days, right? Red brown scab. 4 to 7 days, brown black scab. More than 7 days, depigmented scab or depigmented patch, because scab falls down, depigmented patch is there. Okay. So by concluding aberration, I'll tell you few more one-liners with respect to aberration. See, aberrations are the most common mechanical wounds. So remember, most common mechanical wound is aberration. Most common mechanical wound is aberration. Medico-legally, more significant wound is aberration. Most common as well as more significant wound is aberration. So why medico-legally aberration is more significant? Because of two important points. One point is aberration is always a contact wound, which means aberration occurs always at the site of impact between the force and the skin, right? Or force on the body. So always contact, always a contact wound, most common wound, most medico-legally significant wound, right? One more important point is aberration heals without scar formation. without scar formation, right? Without scar formation. So next slide, please. In the next slide, I'll show you 3 types of lacerations, right? 3 types of lacerations. See, by incised wounds and stab wounds, we have identified the difference between laceration and incised wounds, right? So it is so easy to finish laceration, right? So there are 3 types of lacerations. Lacerations are nothing but tear, right? Tear, irregular tear. You take a piece of paper, tear it, right? Tear it, irregular tear. It is nothing but laceration, irregular tear. See, another meaning for laceration is irregular tearing, right? Irregular tearing. Okay. So the first type of laceration is stretched laceration, stretching, right? Stretching a tissue beyond its limit of elasticity, right? It is called Hooke's law. Stretching the tissue beyond its limit of elasticity causes stretch laceration. This stretch laceration is due to hyper stretching, right? It is usually present in axillary area, axillary folds or groin, right? Or groin. So due to excessive stretching beyond the limit, stretch laceration. Then comes split laceration. The photo, please. Split laceration. The split laceration we have already seen with respect to incised wounds. How do we differentiate split laceration from incised wound? One of the repeat MCQ, right? So here I'll tell you, split lacerations will have irregular margin. See, all lacerations will have irregular margin. So split laceration will have irregular margin. So the photo, please. Split laceration will have irregular margin, right? Irregular margin. Margin will have aberration or contusion. Margin will have aberration or contusion, right? There will be tissue bridge. So tissue bridges are nothing but intact fibers, intact vessels, intact nerves, or incompletely torn tissues at the base of laceration. Incomplete, it is called split laceration at the base, tissue bridge. So tissue bridges are nothing but incompletely torn tissue fibers, right? Okay, so stretch laceration, split laceration. And third one is avulsion laceration, right? Third one is avulsion laceration. See, another name for avulsion is flaying. That was named question 2 years back. Flaying is, that is the question. Flaying is kind of avulsion, a kind of laceration. See, flaying or avulsion is nothing but, right? Nothing but a grinding force, right? A grinding force, a run over, right? A wheel run over, lorry run over, an auto rickshaw run over. So there will be a grinding force, right? A grinding force that detaches most of the soft tissues from its attachment. So there will be detachment of most of the soft tissues from its site of attachment, right? Leaving behind only a residual attachment. Right? Okay, so avulsion is a grinding force taking away a chunk of tissue from its site of attachment, leaving only a small site of attachment, right? So this is avulsion. So we have finished aberration and laceration. So in the next session, we'll see about contusion, right? So thank you.
Kindly enable the video, please. So good evening, everyone. Today we'll start about the important viral, fungal, and the bacterial keratitis. Okay. So corneal ulcer is one of the important questions from the entrance exam point of view. So we should know about the various types of corneal ulcer, its manifestations. Okay. To begin with, we start with the bacterial corneal ulcer. So bacterial corneal ulcer, the most common question they ask, the organisms which penetrate an intact cornea. So we should know the organisms which penetrate the intact cornea. So the mnemonic we can remember here is H1N1Cl. Okay, so H stands for Haemophilus influenza. N stands for Neisseria gonorrhea and Neisseria meningitis. Cl stands for Corynebacterium diphtheria, and L stands for Listeria species. So this is the mnemonic to remember the organisms which penetrate an intact cornea. Okay, these are the important organisms which penetrate an intact cornea. So we should know the various stages of healing of a corneal ulcers, how the corneal ulcer specifically heals. We should know the various stages. Okay, so the various important stages are: stage of infiltration first. Stage of infiltration is the first stage. Then we have the stage of active ulceration. Next is the stage of regression. And last is the stage of cicatrization. Okay, so stage of infiltration, active ulceration, stage of regression, and cicatrization. Okay, this is the typical bacterial corneal ulcer. You see the presence of a the site of the ulcer and the hypopyon is clearly seen in this bacterial corneal ulcer. So again, depending upon the ulcerative process, okay, depending on the ulcerative process, the cornea can become thinned out, okay, and so what can remain is just the Descemet's membrane, which is known as the desmetocele. So if there is a virulent organism, or if there is a highly virulent organism, and absence of treatment, the progression of the disease can be very rapidly, resulting in a rapid ulcerative process, resulting in a desmetocele formation. This desmetocele, if it perforates, it results in the formation of an adherent leucoma. What is adherent leucoma? Adherent leucoma is the iris from underneath comes and seals the wound. So the iris from underneath will come and seal the wound, thereby preventing the further progression of ulceration. Okay, this is known as your adherent leucoma. The final stage is the development of an anterior staphyloma. Okay, so starting the desmetocele, followed by the adherent leucoma, and finally we have the anterior staphyloma. Okay, so we should know the specific named corneal ulcers. Okay, one is ulcus serpens. So which is the organism which causes ulcus serpens? So remember, the bacterial corneal ulcer caused by pneumococcus. Okay, so pneumococcus is known as ulcus serpens. Okay, so if you have a patient with a non-healing bacterial ulcer, corneal ulcer, how do you manage this patient? Okay, so you should know about the treatment for a non-healing corneal ulcer. So we can either do, first thing is debridement. So the dead and devitalized necrotic tissue can be removed. Debridement includes the removal of the necrotic tissue. Okay. Second is chemical cauterization. So which is the material which is used for chemical cauterization? So we can use trichloroacetic acid. Okay, trichloroacetic acid is the chemical used for chemical cauterization. Next, if there is a impending perforation, so impending perforation, we can seal the perforation with a cyanoacrylate glue. Okay, cyanoacrylate glue can be used for sealing the perforation. The last is the presence of a Gunderson flap. What is Gunderson flap? So Gunderson flap is the conjunctival hooding. Okay, the conjunctival hooding which is done in a non-healing bacterial ulcer. Okay, the conjunctival hooding in a non-healing bacterial ulcer is known as the Gunderson's flap. This can be a potential question for your INICET. The last is the bandage contact lens. So we can either remove the necrotizing tissue, dead necrotic tissue, which will help in the healing of the ulcer. We can do chemical cauterization with trichloroacetic acid. In an impending perforation, we can use glue, mainly your cyanoacrylate glue, and the Gunderson's flap, which is the conjunctival hooding at the site of the bacterial corneal ulcer to promote the healing is known as Gunderson's flap. The last is the bandage contact lenses. Okay, the corneal ulcers or the corneal opacities can be classified into various named opacities, mainly a nebula, macula, leukomatous, based on the involvement of the cornea. So if it is a superficial involvement, only the superficial stroma and the Bowman's. Okay, if it is more superficial, if there's involvement of only the Bowman's membrane and the stroma, it is known as your nebular opacity. Okay, so nebular opacity is involvement of the Bowman's membrane and the stroma. Next, the macular involvement, at least half of the corneal stroma should be involved. To call it a macula, half of the corneal stroma should be involved. Leukomatous opacity is a dense white opacity wherein more than half of the corneal stroma is involved. So whenever there is more than half of the corneal stroma involvement, it is known as a leukomatous opacity. The last is the adherent leucoma. I told you the next stage is the formation of a desmetocele. If this desmetocele ruptures, the underlying iris will come and plug the wound, which is known as an adherent leukoma. The adherent leukoma is the nature's mechanism of preventing a complete corneal melt. Okay, the last stage is the stage of the anterior staphyloma. Okay, so among these, we should remember that the maximum light scatter is caused by the maximum light scatter is caused by the nebular opacity. Okay, maximum light scatter is caused by the nebular opacity because of the diffraction of the light. Okay, it causes severe diffraction of the light. Hence, this is the most discomforting for the patient. Among the nebular, macular, and the leukomatous, if they ask you which is most discomforting, it is the nebular opacity because it causes a maximum light scatter, thereby leading to irregular diffraction of the light because of the irregular astigmatism due to irregular astigmatism. Next, we go to the herpes simplex virus keratitis. Okay, this is the HSV keratitis. The typical appearance of the herpes keratitis is the presence of a dendritic ulcer. So whenever a patient with simple herpes simplex is treated with steroid, it can progress to a geographical ulcer. So geographical ulcers, so remember, steroids are an absolute contraindication in epithelial involvement because the superficial dendritic ulcer can progress into a geographical ulcer. Okay, geographical ulcer is because of a steroid given in a patient with dendritic ulcer. Okay, next you have to remember the other named keratitis. Okay, you should know about disciform keratitis. What is disciform keratitis? So it is the endothelitis involving the center of the cornea. So if there is an involvement of the endothelium involvement in the center of the cornea, it is called as a disciform keratitis. Next, we should know about the trophic ulcer or metaherpatic ulcer. So this is the trophic. So disciform, I told you, is the endothelitis. Central endothelitis is known as the disciform keratitis. The metaherpatic ulcer is the trophic ulcer, which is not due to active viral inflammation, but is due to the denervation. Okay, there is no active viral multiplication. The progression is due to the denervation. Okay, denervation and because of the drug toxicity. Okay, so the metaherpatic ulcer is not due to the active viral replication. It is due to the denervation and the drug toxicity. This is the metaherpatic ulcer. So we should know about the various continuous cell lines used for viral culture. Okay, they can ask you the continuous cell lines which are used for viral culture in herpes simplex. Okay, so the important cell lines include the HeLa, the Hep2, and the McCoy. Okay, they can ask you what are the important cell lines which are used for viral culture. It is the HeLa, the Hep2, and the McCoy cell culture. Okay, so we know the treatment here is 3% acyclovir eye ointment given 5 times a day. You can also give 1% okay ointment, and we can also give 1% trifluviridine Okay, and bromovinyl deoxyuridine. Okay, 1% bromovinyl deoxyuridine. So all these are available as ointment. Okay, so the trifluridine is available as drops. Acyclovir is available as 3% eye ointment. 1% bromovinyl deoxyuridine is available as ointment again. Okay, so this is the important point about herpes simplex. Next, we go to another important topic, herpes zoster infection. Okay, so remember, herpes zoster is more common in case of immunocompromised patients. Okay, immunocompromised patients, patients with HIV, patients with compromised patients such as patients with HIV, patients with leukemia, patients with tuberculosis. Hello. So yeah, sorry. So it is more commonly seen in immunocompromised patients, patients with leukemia, patients with tuberculosis. Okay. What is the Hutchison rule? So the Hutchison rule is, so involvement of the tip of the nose. Okay. The involvement of the tip of the nose indicates that there is in association with the skin lesion, there will be eye involvement. Okay. According to the Hutchison rule, whenever there is the involvement of the tip of the nose, so in addition to the unilateral skin lesion involvement, there is involvement of the eye. Okay. There is eye involvement if there is involvement of the tip of the nose. So this is the Hutchison's rule in herpes zoster ophthalmicus. Okay. So next we go to another important topic. So what are the important lesions in case of this one? The corneal lesions, we include the punctate epithelial erosion. So in the epithelium, it can result in a punctate epithelial erosions. So this is typically associated with filamentary keratitis. Then we have the microdendritic ulcers. Okay. Then next is the nummular keratitis. Nummular keratitis. The last is the involvement of the disciform keratitis. The presence of disciform keratitis. Disciform is the endotheliitis which is associated with edema in the central area. Okay. So this is the endotheliitis with involvement of the central area. Okay, this is the herpes zoster ophthalmicus. Okay, next we go to another important topic. So fungal corneal ulcer. So remember, which is the most common organism causing the fungal corneal ulcer? The most common organism is the Aspergillus fumigatus. Aspergillus fumigatus is the most common organism causing the fungal ulcer, and most commonly the commensal organism in the eyelid include the Candida and the dermatophytes. So the typical history in a patient with fungal corneal ulcer is the history of injury with a vegetative matter. So because of the involvement of injury with the vegetative matter, the signs are more than the symptoms. Okay, another typical feature is the first is the injury with vegetative matter. The second important point is these signs are more than the symptoms. Okay, so also they also have a typical feathery margins. Okay, the appearance of this feathery margins, feathery with a hyphae margins. Another important point is the presence of an immune ring, which is known as the Weasley's immune ring. Okay, so remember, Weasley's immune ring is not only a characteristic of fungal corneal ulcer, it can also be present in acanthamoeba. Okay, so Weasley's immune ring is both a feature of both fungal corneal ulcer and your acanthamoeba infection. Okay, so most effective drug, remember, for filamentous fungi, they'll ask you the drug of choice. The drug of choice for filamentous fungi is natamycin. Remember, Natamycin is the drug of choice for filamentous fungi. The most common filamentous fungi causing fungal corneal ulcer is the Aspergillus fumigatus. So typically there will be a history with vegetative matter. The patient will have signs more than symptoms, presence of a Wesley's immune ring and a feathery hyphae margin. Okay. So what are the important investigations you'll do in a fungal corneal ulcer? So you'll do staining with 10% KOH, 10% KOH, gomorimethionamine silver, What is the culture medium used? Culture is your Saboruch dextrose agar. Saboruch dextrose agar. Okay. And what is Cogan syndrome? So Cogan syndrome, the triad in Cogan syndrome, typical triad is the interstitial keratitis, sensorineuronal hearing loss. Patient will have vertigo and tinnitus. This is an autoimmune inner ear disease. Okay. The corneal sensations are reduced because of the interstitial keratitis. The patient has sensorineuronal hearing loss, vertigo, and tinnitus. Next, last important topic is the acanthamoeba infection. Okay, acanthamoeba, you should remember, it is a non-dependent on the human host for survival. Remember, first very important point is it is non-dependent on the human host for survival. Okay, so important points about acanthamoeba. First important point is it is a ubiquitous free living organism. Okay, ubiquitous free living organism. Second important point is cysts are highly resilient. Okay, they can survive even hostile environments. Okay, the cysts are highly resilient. Another important point you have to remember is, so human infection occurs prior to a corneal aberration. There should be a corneal aberration for the human infection to occur. It usually occurs due to the cleaning the contact lens with the distilled water. Okay, cleaning contact lenses with distilled water. Instead of using the normal contact lens solution, people who clean it with tap water or distilled water are more prone for the acanthamoeba infection. What are the important clinical features? Remember, the most important clinical feature in acanthamoeba which they ask you is the pain is out of proportion to the pain is disproportionate to the extent of the ocular involvement. Okay, they have a disproportionate pain. The second important is the presence of pseudodendrites. It's not a true dendrites like your herpes simplex. It is a pseudodendritic ulcer. The third important point is the presence of satellite lesions, like your fungal corneal ulcer. This also has a satellite lesion. Satellite lesion. This is the presence of a hypopion. So remember, what is the stain which is used for smear which is used for staining this one? It is the calcol flower white. Calcol flower white. And what is the culture media? Remember, the culture media here is the non-nutrient agar with the E. coli overlay. The non-nutrient, again, this is a potential question. They've asked this many number of times. The non-nutrient agar with an E. coli overlay. Okay, so the treatment, as we already know, it is PHMB, polymethyl hexabiguanate, chlorhexidine, and propamidine or pentamidine. Okay, chlorhexidine and propamidine and pentamidine. So quickly revise, most important point you have to remember in acanthamoeba is the pain is very disproportionate, presence of satellite lesions and pseudodendrites. Smear is stained with calcol flower white. The culture medium, very important, non-nutrient agar with an E. coli overlay. Okay, non-nutrient agar with E. coli overlay. Remember, the cysts are highly resilient. They can infect only after a corneal aberration. So we quickly go to the question. So the drug of choice for the treatment of a corneal ulcer caused by filamentous fungi is Remember, I told you the most common filamentous fungi is Aspergillus fumigatus, and the drug of choice is natamycin. Okay, the answer is natamycin. The most common presenting feature of acanthamoeba infection. This is one of your NEET questions. Okay, so remember, the most common, this one is the pain. Disproportionate pain is one of the characteristic feature because of the perineuritis. The pain in acanthamoeba is due to the severe perineuritis. Hypopyon is seen in fungal corneal ulcer, pneumococcal corneal ulcer, gonococcal corneal ulcer, or all the above. So the answer is all the above. Next, herpetic corneal ulcer is diagnosed by, so Giemsa stain, ELISA stain, cell culture PCR, or rose Bengal staining. Okay, so the answer is cell culture PCR. So you should also know, in case of herpes simplex, we should know of something called as double staining. Double staining of the cornea. So what is this double staining of the cornea? So when we use two dyes, one is the fluorescent dye, the second is the rose Bengal. Okay, rose Bengal stain. So what happens when we stain the cornea with both the fluorescent and the rose Bengal stain? The floor takes up the fluorescent stain while the edges takes up the rose Bengal stain. So the edges take up the rose Bengal stain while the floor takes up the fluorescent stain. Okay, remember, rose Bengal stain, it stains the dead and devitalized tissue. It stains typically only the dead and devitalized tissue. So the edges of the ulcer will take up the rose Bengal stain. The fluorescent staining is taken up by the floor. Okay, this can also be a potential question in the upcoming exam. Next, a patient presents with the OPD and a diagnosis of fungal keratomycosis is made. Which of the following drugs would be very effective? Doxycycline, sulfur sulfadiazine, vancomycin, linezolid. So we know sulfur sulfadiazine is the newer drug for keratomycosis. Okay, so the answer is topical sulfur sulfadiazine. Okay, so with this we will finish the class for today. Okay, so we'll resume the remaining topics on Monday.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Hello, am I audible? Okay, let's start. Hello everyone, I'm Dr. Sneha and today we'll be discussing briefly on the topic of multiple gestation from obstetrics, okay? So let's go to the first question. Which of the following is false regarding monochorionic twin? Okay. The key word here is monochorionic twin. The first option shares one common placenta. Second, no chance of complications. Third, induced for labor at 36 to 37 weeks. Fourth option is monochorionic twins or same or different sex. Okay. So you should choose which one of the following is false. The answer here is D. Okay. Monochorionic twins has one placenta. Because they share a single placenta, there is more chance of complications, and usually they are induced at before they go into spontaneous labor because there's chance of stillbirth if you let them to reach till 40 weeks. All right. Now let's see why this is the correct answer. Quickly, let's revise what each of these following terminology means in multiple gestation because it's always a source of confusion. First is zygosity. There are two types, right? Monozygous and dizygous twin. Zygosity means the number of eggs that were fertilized by a sperm to form a baby. Okay. Chorionicity again can be dichorionic or monochorionic. And chorionicity simply means number of placenta. Okay. Amniocity is the number of amnion or the membrane that divides the 2 or 3 babies, whichever the order of twins. All right. So first, let's take the case of dizygotic twin because it is easier to understand. In dizygotic, 2 eggs will be released in a cycle, and each of these 2 eggs will be fertilized separately by 2 sperms. Okay, which will get implanted on the uterus, and it will form a 2 separate babies because each of the babies are formed by one separate egg and a separate sperm. Each of this baby will have their own placenta and their own amniotic cavity. Okay, suppose if this is the baby, each of them will have their own separate placenta and own amniotic cavity. So that means two separate placenta, that means it becomes dichorionic, and two separate amniotic cavities, so diamniotic. So by default, all dizygotic twins are DCDA twins. Let's look at how monozygotic babies are formed. Monozygotic, mono means one, right? So one egg fertilized by one sperm. And because of some reason, this divides. Okay, this single zygote divides, and depending on when this division takes place, the chorionicity and amnionicity is determined. If the division takes place very early, at less than 3 days after fertilization, the division will take place completely, and there will be two separate placenta, two separate amnion with two separate babies. Okay, so this will be DCDA twins, dichorionic, diamniotic. Whereas if the separation takes place between 3 to 8 days after fertilization, the sharing of placenta alone will not happen. So there will be one single placenta, okay, but two babies, and there will be two separate amnion, two separate amniotic cavity, but there will be only one placenta. So this is called as monochorionic because there is only one placenta. But since there are two separate amniotic cavity, it will be called as diamniotic, MCDA. If the separation happens between 8 to 13 days, the amnion also will not divide. So there will be one single amniotic cavity and one placenta, and two babies will be floating in the same amniotic cavity. This is called monochorionic, monoamniotic. If the division takes place more than 13 days, very late division, the baby themselves will not separate and it will form conjoined twin, and depending on where the baby is fused together, there will be different types of conjoined twin. Okay, so in monozygotic, the outcome is quite different. The chorionicity and amnionicity, there are 4 types depending on when the division happens, when one zygote divides into different parts. So if it is less than 3 days, two babies, two separate placentas, and two separate amniotic cavities. If it is between 3 to 8 days, there will be a same placenta, but they will still have two separate amniotic cavities. 8 to 13 days, same placenta and same amniotic cavities. More than 13 days, the baby themselves will not be divided completely. It will result in conjoined twins. Okay, and because dizygotic twins are fertilized by two different sperms in two different eggs, this sperm, now egg is always X chromosome, the sperm can be X or Y. So depending on which sperm is fertilizing these two eggs, it can be XX, XX, or it can be XY, XY, or it can be XX and XY, different combinations. So the baby can be same sex or different sex in dizygotic. Whereas in monozygotic, one egg is fertilized by one sperm, and the sperm can either be X or Y only. So the zygote that is formed will be XX or XY, not both. So the sex will always be same in monozygotic. Okay, hope that's clear. So chorionicity is the most important thing that has to be determined in multiple gestation, because this will determine the outcome of the multiple gestation. As a rule, dichorionic twins or babies having their own placentas usually have better outcomes. When babies start sharing placenta, that is monochorionic, there is more complication, which means you'll need more monitoring during antenatal period to make sure that these complications are avoided, or even if they arise, you can tackle them immediately. Okay, and this chorionicity is best determined in the first trimester. As the baby becomes bigger, it becomes more difficult to determine if the baby is sharing the placentas or having two different placentas. Usually, this is done between 11 to 14 weeks. When a patient comes for NT scan, nuchal translucency scan, if you can correlate, it is around the same time when the patient comes for nuchal translucency scan, not very early also, because the membranes and placenta might be too small or too thin and it might be difficult. So 11 to 14 weeks will be a very optimal time to determine the chorionicity. Suppose if the patient comes for late booking and you miss this window, and you're not able to determine the chorionicity, you should always consider or assume that it is monochorionic. Always think of the worst case scenario so that the mother will be monitored properly so that the complications can be picked up. Okay. So now let's see in this 11 to 14 week scan, how do you differentiate if it is dichorionic or monochorionic using ultrasound? Usually done by transvaginal method in the first trimester. In dichorionic, the dividing membrane will be more than 2 millimeter thick because there will be two separate amniotic membrane. Okay, whereas in monochorionic, usually it will be a thin membrane, less than 2 millimeter. Dichorionic, number of membranes, that is number of amniotic membranes, there will be 3 to 4 layers. This you can appreciate after delivery when you're examining the placenta. Whereas in monochorionic, it will usually be 2 layers. Okay. The number of placenta in dichorionic, as the name implies, will be 2 placentas. Whereas in monochorionic, there will be only 1 placental mass. In dichorionic twin, if it happens because of dizygotic, then it will be same or different. Whereas if the dichorionic twin is as a result of monozygotic, it will be same. So the nutshell is it can be same or different sex. But again, this is not something that we can find out by scan in India because gender identification in India before the baby is born is illegal. In monochorionic, since all monochorionic result from monozygotic twins, the gender will always be same. The very specific ultrasound sign that you look in dichorionic is called as lambda sign or the twin peak sign. Whereas in monochorionic, it is called as the T sign. Now let's look at the ultrasound picture and see how we can determine whether it is lambda sign or T sign. So just a gross outlook, these two black cavities are the two separate amniotic cavities, okay? And these homogeneous blobs are the babies. And can you see a membrane-like structure that is dividing these two? If you notice, it is in shape of a triangle. There is something in between the two membranes, okay? It looks like lambda. This is lambda sign. So it is not a straight line, but in the place where it originates from the placenta. This is the actual placental mass. And if you see the membrane that originates from this placenta, the originating point is actually thicker and it becomes thinner as it goes and attaches to the other side. This is because a part of the placental mass enters between the two amniotic membrane, and this is what causes this thickness. Okay, so this is called as the lambda sign or the twin peak sign. Very characteristic of dichorionic twins. Okay, whereas in T sign, here you can't see the baby, but if you can see, there are two amniotic cavities and there is just a simple line. Now this is the placenta. This homogeneous mass is the placenta. If you can see, it is just a thin line that is arising from the placenta. Okay, so this is called as T sign, and this is characteristic of monochorionic twins. Okay. Now let's go to the next question. Which of the following is a complication that is specific to monochorionic twins? Your options are congenital anomaly, discordant growth, prematurity, and monoamniotic twins. By common sense, you can actually rule out and come to a conclusion because monoamniotic twins can happen only in monochorionic twins, right? Because in dizygotic twins, most of them, all of them are DCDA. And if there are two separate placenta, it means they will always have two separate amnion. Only in monochorionic twins, monoamniotic variety is possible. So the answer here is monoamniotic twins. All right. So now let's quickly look at some of the complications of dichorionic and monochorionic twins. First, let's look at the complications that are common to both, and then let's go to the monochorionic one. The common complications for both dichorionic and monochorionic are miscarriages. Miscarriages are more common in twin or multiple gestation. Congenital anomalies are also higher because it's either, especially because when a single zygote divides, there is a chance that the baby's parts will not be formed properly. All right. And there can be discordant growth. That means one baby will be bigger than the other baby because of differences in the size of the placenta or differences in the blood flow to each of the twin. So if the growth difference between the bigger and smaller twin is more than 20%, we call it as discordant growth. And a very common complication is prematurity. Almost close to 50% of multiple gestation will go into preterm labor because of the heavier weight. The womb is carrying much more weight and much more content compared to a singleton pregnancy, which will cause more pressure on the cervix, and this can cause premature birth. Okay. Whereas in monochorionic, the complications are, remember all of them, lots of T's. Okay. First is twin-to-twin transfusion syndrome. Second is twin anemia polycythemia syndrome. Then you have twin reverse arterial syndrome, pressure syndrome, perfusion syndrome, TRAP. And last you have conjoined twins. Now, all the T's happen because there is a single placenta, there is a link or there's a communication between the blood vessels of the two twins, and there is unproportionate or unidirectional flow of blood from one baby, the donor usually, to the recipient baby. Okay, so there is a unidirectional flow. Usually what we want is that even if the placenta is same and if there are two babies, you want the blood flow to be bidirectional so that both the babies get equal amount of blood. Because of some reason, if there is only blood flow from one baby or one blood vessel to the another, one baby becomes donor and the other baby becomes recipient. Okay, in which case all these complications starts happening. Let's quickly look at twin-to-twin transfusion syndrome because this is a very high yield topic. Twin-to-twin transfusion syndrome occurs because of the deep AV connections, which means, so as I mentioned earlier, there is a single placenta, one single placenta, and there are a lot of blood vessels of one baby one getting connected with blood vessels of baby two. Usually the connections are between two arteries or two veins, in which case the pressure will be same, so there will be bidirectional flow. When this connection happens between artery of one twin and vein of another twin, artery has high pressure and vein has low pressure. So because of this pressure difference, there will be blood flow from one twin to another. There will be unidirectional blood flow from the artery to the vein. The baby that gives off the blood is called as the donor twin, and the baby that receives all of this extra blood is called as the recipient twin. Okay, and usually the complication is more for this recipient twin. What happens is that the donor twin, because it keeps pumping blood into the recipient twin, there will be reduced blood flow in the donor twin, which causes reduced blood flow to the kidney, so reduced urine output, which means reduced amniotic fluid around it, so there will be oligohydramnios. Okay, whereas in recipient twin, what happens is that more blood flow, which leads to more perfusion of the kidney, more urine output, so there will be polyhydramnios. And what happens in adult if you overload them with fluid? It leads to pulmonary edema and cardiac failure. The same thing happens to recipient. Because of increased blood flow, there will be cardiac failure. Too much blood for the baby to handle. So it leads to cardiac failure. So the recipient twin, the complication or the outcome is bad compared to the donor twin. All right, so this is twin-to-twin transfusion syndrome, and it occurs because of the connection between the arteries and veins in the deeper part of the placenta in comparison to twin anemia polycythemia syndrome, where the connections are between the smaller arteries and veins in the placenta. Okay. Now you can quantify TTTS. The severity of TTTS is quantified by a staging called Quintero staging. And there are 5 stages. So depending on the severity, you can provide the patient with the proper management. The first stage is when the bladder is seen in the donor twin, which means that the kidney is still being perfused well in the donor. The blood flow to the donor twin is still normal. It is not compromised. Okay. In the second stage, the bladder will not be seen, which means that the perfusion is slowly starting to decrease in the donor twin. And so the urine that is formed becomes very, very less in the donor twin. So as a result of which the bladder will start not being visualized in the scan. Stage 3 is when there is Doppler changes in either of the baby, like reduced flow, absent diastolic flow, or reversal of diastolic flow, or ductus venosus changes. So this is stage 3. Stage 4 is when there is frank ascites or hydrops. Usually this will be seen in the recipient twin because of the fluid overload. Okay. Stage 5 is the worst scenario, where will be death of either of the twin, either the donor or the recipient. Okay. So you stage the disease and then you see what is the gestational age of the mother and you provide them with the management. The best management option that is available for TTTS is called as the laser ablation. There are many options available. You can leave them as such, which is called expectant. You can make a hole in the amniotic membrane in between to make sure that the fluid between the two babies is balanced. That is called septostomy. Or you can do amnio reduction in the baby with the polyhydramnios in the recipient, so that the volume of amniotic fluid is reduced. Okay. But the best treatment that is available now is called laser ablation. This means that the connection between the artery and the vein of two babies, this is the donor and this is recipient, artery, vein, and this is where it gets connected, right? So this is the culprit. So what you do is that you insert a laser instrument through the womb into this place, and by laser you ablate all these vessels. That is, you coagulate all these vessels so that this connection is lost. So now the donor will get its own blood supply and the recipient will get its own supply. That is what you mean by laser ablation. Okay. Let's go to the next question. G2P1L1, 36 weeks of gestation, DCDA twins. First twin is in breech presentation. Previous delivery was by cesarean section. She is keen on having a vaginal birth after cesarean delivery. Basically, she wants a normal vaginal delivery this time. So what will you offer her? Your options are: provide her with external cephalic version, or you provide her with VBAC, plan for elective cesarean section, or plan for an internal podalic version. So let's look at the mode of birth in multiple gestation quickly. Now you have to make sure that the patient does not have any contraindication for normal vaginal delivery. So let's look at the indications of cesarean section. First one, if the first twin is non-cephalic, it can be breech, it can be transverse. When the first twin is not cephalic presentation, labor can get very complicated, so you post them for cesarean section. Second, if the type of twin or multiple gestation is monoamniotic. If there is only single cavity, both the twin can start interlocking. And because of interlocking, there will not be a smooth delivery of one twin followed by the another twin, and there can be difficulty in delivery and the fetal parts can get stuck inside. So monoamniotic twin directly go for cesarean section. If there is severe IUGR, growth restriction along with Doppler changes, they might not tolerate the stress of labor and it can cause severe hypoxia and even stillbirth. So you go for cesarean section. And the fourth is higher order, triplets or more. Triplets, quadruplets, all these multiple, more than twins, anything more than triplets. Again, all the baby parts can get interlocked and you don't know which baby will come out first, lot of complications. So you post them for cesarean section. Okay. If none of these is present, then you can offer her normal vaginal delivery. So the only condition for normal vaginal delivery is the first twin should be cephalic. And ACOG says that VBAC is allowed in patients with twins, twin gestation, not for triplets or more. If she's had just one previous lower segment cesarean section, then yes, VBAC is allowed. Okay. So the condition for normal vaginal delivery is all of these indications for cesarean section should not be present. First twin should be cephalic, and if the patient has had one previous LSCS and if it is twins, you can still give her a chance of VBAC. So let's go back to the question. BCDA twins, first twin in breech presentation, previous LSCS. So here the contraindication for a normal delivery will be the breech presentation. The first twin is non-cephalic, breech. Suppose if the scenario was like it was cephalic presentation instead of breech with previous LSCS, yes, you can still go for offer her VBAC. But since this is first twin breech, your option correct answer will be to have an elective cesarean section. Let's look at the other options. External cephalic version is done for a singleton breech presentation presenting at term to convert it into cephalic. Otherwise, in twin gestation, when the second of twin is breech or transverse, you can attempt to turn it to cephalic. So this applies for a singleton breech or second of the twin with breech or transverse. VBAC, if the first twin was cephalic, yes, in this scenario, you could have offered her VBAC. Internal prodalic version is again something that is done in the second twin. First twin is already delivered. You're expecting the second baby to be delivered, but it is non-cephalic. It's either breech or transverse. You put your hand inside the womb and grab hold of the baby's legs or foot and then pull it out to deliver. So the only difference between external and internal is that external, you rotate the baby by keeping your hands on the mother's tummy and rotate it, whereas internal, you put your hand inside, grab hold of the foot and pull it out. Okay, so both these conditions are only for the second of twin during labor. ECV before labor for singleton breech or during delivery for the second of twin when it is non-phallic. So the answer here will be elective cesarean section. Okay, so that ends today's session. Hope that was useful. Thank you very much, everybody.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Good evening, one and all. Today, we'll discuss the remaining few MCQs in leprosy, and we'll move on to sexually transmitted diseases. So,